go straight. Yeah, and then I'll dive straight in. Well, with Amrish, who will first give us a little overview of the epidemiological situation of COVID. So Amrish, over to you.
Just have to find my unmute button and take this one to full screen. There we are. Good evening, everybody. And yeah, it's nice to be here and to see you all. We named this session the COVID pandemic and the Omicron variant, the certainties and uncertainties, especially in this stage of the pandemic, especially for those from Europe. There's a lot of talk about, is this really the last phase of the pandemic? In what direction are we going? And I'm just going to give a brief outlook on where we stand before we go to the questions and answers with all the wonderful questions that already came in, and make an attempt to, to formulate an answer to those. The current global picture. As we all know, infections are explosively rising, especially in the European region. You can see that right here in the graph. So you see that, for example, the European regions, so really sharp increase of infections increasing. And of course, that's then also tend to increase, but not as quickly as they did, for example, as you can see here in the past waves that we had. And of course, there's a logical explanation for that. That's mostly the vaccines doing their work. Vaccines work. We see that people who are vaccinated, that they way less often end up in the hospital, for example, in regular care or in intensive care compared to those unvaccinated. And the effect is even more visible and stronger for those who got a booster, their third vaccination, or in some cases, even the second vaccination in a more recent time. We also know that the booster is not perfectly adapted to Omicron, but it does give the immune system an extra reminder that it needs to be on the lookout for COVID. So what we call, it generates an antibody response very quickly, and therefore you get a little bit extra protected. So yes, even though it's not adapted fully to the Omicron variant and still is based on the previous Delta variant, it's important to take it. Vaccines that will be, although fully adapted to Omicron, they will be getting on the market in April, which means that with this new, let's say, iteration of the vaccines, will yield better protective effect and even less risk of people getting hospitalized. Now here I have a little bit of a complex looking map for you all. On this side, you see the world. And on the other side, you see what we call a so-called phylogenetic tree. And in this tree, we try to visualize the different types of variants that go by over time. And you can see that time moves here from December 2019, when the first virus was picked up, mostly in Asia and China, up till, let's say, the period now where we are with the Omicron variant. And it's actually an animation that I picked up, and now I have to see if I can get that working. So you see time moving. You see here the initial variant finally being picked up, because in the beginning, nobody was really looking for different variants. Here we see that we sequence and we type more over the world. Here on the top, you can now see the entrance of the Delta variant making its entry. Oh, and I think my PowerPoint just crashed. Oh, 1 second, let's see if we can get it back quickly. That always happens with technology, even though during 2 years where we're completely virtual. There we go again, share screen. So I think we're back. There we are. And you can see on the top, in a few minutes, that's when the Delta variant made its entry. And of course, this Delta variant we know was more infectious and it spread really quickly. And there you see it coming up, and it really filled the proportions, as you can see on the world map. And then recently, in November, December, the Omicron variant became very dominant. And that's kind of like how the scope was in this pandemic, that these variants tended to change the course of the pandemic And they always kind of came unexpected onto the stage. And therefore, we were hoping a lot, but the image changed. And therefore, the pandemic never really ended, but we all became a little bit more tired of it. I'll come back to this slide in a bit. Now, if you look at the Omicron global spread at the moment, in actually all regions of the world, it's the most dominant variant that is going around. In a few regions, we have seen that the Omicron variant is there, but there's no capacity to determine what the differences are between different variants. Those are, for example, the countries that are a little bit colored in orange or in yellow. The white countries are, of course, the countries where there's probably least capacity to make a determination, so we don't have a clear image at all. But definitely in our region of the world, let's say in the global north, you can see that it's very dominant. Now, there are knowns and unknowns now that Omicron has set the stage. So ironically, to learn much about the virus, you need some of the virus being circulating, because this way we can see what were the properties of Delta, and now that Omicron has made an entry, what are the properties of Omicron? That means if you want to know if it spreads faster, you can only say something about it if you have sufficient Omicron circulating. If you want to know if it leads to more death, the more difficult it sounds, it means you need more people in the hospital. So it takes time to learn the properties of a virus. By now, we do know that Omicron is actually milder in disease, but it spread faster. There are, although not huge differences in the disease patterns for those highest at risk. And of course, the reason why we see less people coming into the hospital in this wave is because many people have gotten the virus, or even better, many people have gotten vaccinated and very well in time got their booster injection. But even though Omicron might be milder, it spreads faster, and a faster spreading variant can sometimes be worse than a more severe variant, especially for those unvaccinated or those that don't react well to vaccines because they have underlying disease or they're immune compromised. Now, the unknowns are really lying into the question, is this the last hurdle towards the end in the pandemic? I think if you've been reading the newspapers globally, in The Guardian, New York Times, or even your local newspapers, people are talking about, is this the end of the pandemic? Are we now going in the so-called endemic stage? Well, unknown. Why? We don't know how long immunity will last and how strong it is. And the big question mark is always, what about these new variants? And that's kind of bringing me back to that picture that I showed you before. You see, like in the beginning, we only had one variant, and that's what we based our strategy on. And also vaccines were kind of developed in that way. And then all of a sudden, there was Delta, which was more contagious. In that way, also bringing the level of number of people that needed to be vaccinated to get a, let's say, an herd immunity type of effect. Well, we needed more people for that. And once we've achieved that, then all of a sudden an Omicron variant passed by, and we saw that this Omicron variant, in the way of its mutations, managed to bypass immunity much better. So the question is, of course, what will happen in the future? So we don't know if this is the end towards a pandemic, and if we are at the endemic stage. If you read the warnings that WHO pronounces, is that COVID-19 has not become endemic. And that's not surprising if you look at the exploding numbers of Omicron infections in many parts of the world now. And even the advisor to the US government, the senior advisor to the US government, Fauci, says that it's way too early to say something about that. And that's why we are still at this two-phase strategies. If we want to put this endemic on a break, of this epidemic, the pandemic at the break, there's two strategies that we need to walk. One is keeping infections low with measures, and we can discuss the ins and outs of measures, and politicians can discuss them, but it's definitely an important part. And the vaccine uptake needs to remain high. And as always in outbreak management, it's about learning. What are we learning of this virus? How do we know what we can do in terms of measures? Which measures are really effective, but also find a balance between their effectiveness and returning to some kind of normality in life. But we also need to be willing to invest in communication and many of the other means to keep people aware of what the situation is and how we can kind of keep it manageable. So yes, we should hope for the best. We should sketch perspective to people, but hope is not a strategy, which is kind of the course of every pandemic, well, person who worked on outbreaks. And that's something that I'm worrying about a lot, is that people say, well, this is the end. Let's stop everything. Let's open fully up our societies and see where it ends up. So that about the current situation. Back to you, Gilles.
Thank you, Amrish, for a very, very good introduction to this session. And now we'll go over to questions, not questions from me, but questions from the many people who sent us questions. We actually received so many questions that we won't be able to address them all, but we try to compile them into thematic. So we'll start with really talking about Omicron itself. So the World Health Organization classifies Omicron as a variant of concern, a VOC. When is a variant considered very worrying by the medical community? What is a variant of concern?
Yeah, so viruses mutate all the time. And most of the time, those mutations don't lead to anything. It doesn't give the virus any added advantage. When there's two designations that WHO has, it's a so-called variant of interest, which sometimes means, hey, this variant might show some negative properties as being it spreads easier or it causes some severe disease, but we don't really have good data yet to say it. Now, once upon a point when they get that data, for example, because there are many cases coming up and there's more data coming from hospitals and from the public health institutes, that is when something can get labeled as a variant of concern because it really has negative properties. Like the Delta variant at the time, which spreads much faster, the Omicron variant that spreads much faster as well. And it was only later that we discovered it was a little bit milder in disease, but still a virus spreading by itself faster is sufficient reason to label it as a variant of concern. Basically giving the message to countries, be aware, check and keep monitoring this virus and what it does, but also prepare yourself in terms of measures that you have to take and let people know that this variant is having a negative impact.
Yeah, thank you. So many people wanted to know what the differences were between previous variants and Omicron. Is it more transmissible? You answered that, yes, it is more transmissible. Does it cause more severe illness? You also answered that saying it is milder, but you said, as you said very well, sometimes a faster spreading virus, even though it might be milder, can be more dangerous because it infects many more people. Why is it that new variants and highly infectious variants continue to appear? And then linked to that is, how can these variants keep circulating even in countries where we have high vaccination rates, such as France or Israel?
So for that, we have to look at what we call immunity. And you can get immunity in two ways. One way is just getting the virus and surviving, that you get the virus, which makes you immune. And the other way, which is the much more preferred way and a much more safer way, is to get vaccinated. Now, we know that for some diseases, vaccines are incredibly effective in protecting you against severe disease, but also very effective in you spreading the virus. For example, in the case of measles, everybody most of the time gets childhood measles vaccines, and we know it's incredibly effective, and that's why we hardly see any measles outbreaks anymore. Unfortunately, for the vaccines for the coronavirus, the SARS-CoV-2 virus, they protect very well against severe disease, although it's a question of how long do they have that protection, especially for people in classical risk groups, but they protect less well against me giving the disease to someone else. That means that if you have a vaccine that is doing its job in the most important part, making sure that people do not die and do not end up in the hospital, but not so good on the transmitting part, it means that you still need additional measures next to the vaccines to prevent transmission. Now, if you have a lot of transmission, which means you have a lot of virus in your population, it also means that by that element, the chances of occurrence of new variants just simply increases. And that's why we are still worried and why we're saying, listen, this is not the end of the pandemic, because there's always a risk of new variants appearing.
Yeah, no, thank you. And this is a perfect introduction to the next question, which is will fit, I'm afraid, in the unknown, because we're asking you to have a crystal ball, but I have to ask it. Will other variants keep emerging in the coming months? Can variants that are as dangerous as Delta or even more dangerous still emerge after Omicron and spread as fast or faster than Omicron? Or does Omicron predict the end of COVID-19? And we know the answer to the last question.
Yeah, Gilles, you answered the question in part already yourself. We don't know. That's why it's important that although we really want to be done with this pandemic, I mean, we're tired of not having a normal life, with seeing each other, with all the testing. Unfortunately, we still need to have that in place, or at least in place in a scalable manner, which means that when by coincidence a new variant appears, which we cannot predict, that we are prepared to deal with that. And that might mean that in the future, we still need to reach out to measures that restrict our mobility, that restrict our social contacts. That's unfortunately the sad reality that we have to be honest as scientists as well. Maybe Omicron is an entry point into the end of the pandemic. That's what we hope, but not something we can be certain of at this stage in time. It's way too early.
Yeah, no, thank you. Now, many of us have already have had COVID. We've been infected. We have antibodies. We have some level of infection. What does that mean for Omicron? Is there a higher risk of reinfection with Omicron after you had COVID after prior infection?
Yeah, I think that the key element in this is time. So let's say that you got an infection from Delta not so long ago. Let's call it 6 weeks ago. You should then still be pretty well protected against Omicron. But let's say your last infection is a long time ago, 6 months ago, and you decided not to get vaccinated. Then your protection might be much lower, which means that you are, again, depending, of course, on your individual image of health, at risk, definitely to be infected. Even if you are vaccinated, you can still get infected. We all might have experienced that in real life as well. But it also means that you will be able to transmit it. Now, for vaccination, it's kind of the same thing. You should see vaccination as an initial wall to prevent severe disease outcomes, which means if you get infected, there are two things that are happening. You're protected, so you will likely not become severely ill and end up in the hospital or even die, but you will also get a boost in your immunity at that point in time. And I think that's the first thing to realize, is that vaccines are building a wall, but that wall needs to be maintained. And that maintainment can happen either by getting additional boosters or by getting infected. But of course, the route of infection is always the one with the highest risk.
Yeah. And then do we actually know how long the immunity to COVID lasts after you've had an infection with, let's say, Delta?
It tends to differ. This is all, I think in the beginning we were sold a little bit that we could vaccinate ourselves out of the pandemic. But we know from different coronaviruses that it's a very complex image. If you look at the MERS coronavirus, which is a much deadlier variant, but fortunately not so fast spreading, and that's why the outbreaks always remain relatively contained. We know that people that get a mild infection, for whatever reason, also unfortunately hardly build up any lasting immunity. People that get a very severe infection and manage to survive it, they often have immunity that lasts, in a period of 6 months. And it seems, at least from the data that we have, let's say on the first, second, and if you look at countries that were very early with the boosters, like Israel and the UK, that the third booster offers protection. But we also know that countries like Israel are already talking about their fourth booster injection because they see some immunity levels of decline in the immunity as well. Now, the best effect, of course, will be achieved when we go towards April and you have a vaccine that is better adapted against the then circulating variant, which hopefully will still be Omicron and not the next one. And that's kind of like, how do you say, the state of arms that we're walking. It's the constant battle between immunity vaccines versus a virus or a pathogen that changes, an image that we also see with other diseases.
Yeah, it's a run. It's a competition between vaccine makers and the new variants, in a way. Let's talk a little bit about vaccines. And you've already said something, but people want to know if the vaccine and the booster protect effectively against this virus, and then specifically against Omicron, and then maybe, again, your crystal ball, how do we think it's going to fare against future variants?
Yeah. So how well a vaccine protects against a certain variant really depends on how the vaccine was developed, in the sense of like, was this vaccine developed when Delta was circulating? Well, for the current state of vaccines, yes, that's the case. Omicron was a virus with a lot of mutations, which means that the virus changed in part its jacket, and therefore the current vaccines still have an efficacy, but it's a little bit less, and that's why we need the boosters. And so in the future, it will also depend how many changes a new virus will have in its jacket to know if the vaccines will remain at efficacy. The other component is, like I mentioned, it's time. We know that at least for the first and second, and partly also the third injection booster that we see now, that immunity does decline a little bit. But immunity is a bit complex. Immunity has two components. It has, let's say, a memory component, and it has like a component that's already there, which we call the antibody response. So what we see is that the antibody response is declining. So that's, let's say, your first line of defense of your immune system. But that second line, that memory response, remains intact. And that means basically that if you're young, vital, and you don't have underlying disease, you will likely not get very sick, even for potential future variants if they don't differ too much. But if you're in a high risk group, you really need that first line of defense. And if you don't have that, then you're again at the higher risk.
Yeah, absolutely. I mean, we also still have imperfect vaccines there. They are good, and they're the best tool we have, but they are not perfect.
Absolutely.
Well, this is an easy one. Do you recommend vaccination?
I do, yes. I mean, like you said, the vaccines are not perfect, but we do it on such a massive scale, and we see such a strong decoupling effect between you getting the virus and people ending up in the hospital. And as soon as we started vaccinated, we saw that less and less people ended up in the hospital. And in the end, much of the response, much of what makes this pandemic so hard is indeed people burdening the health system. It has many consequences. It's not just people ending up in the hospital for COVID, but in many, let's say, of our countries, it leads to other healthcare being postponed. People cannot get critical treatment when everybody is focusing on COVID. And that is a really important element, especially also in countries where health systems are a little bit more fragile. I'm not talking necessarily about the countries that we work in as MSF, although in South America you see that, but I'm also talking about countries in East Europe that often have way less health capacity and really cannot use the burden of COVID. So absolutely, yes, get vaccinated, get your booster. Never in history was there so much research being done into one pathogen. So everybody has their spotlights and the magnification glasses on it. If you're worried about side effects or you're uncertain, speak with professionals. But yeah, definitely do get vaccinated, because they're our best tool in the toolbox that we have.
Yeah, and I mean, for having worked in COVID hospitals in South Africa, I completely agree with you. When we are in a COVID wave, the hospitals were so overwhelmed by people with COVID that all the other pathologies basically had to wait. And those are important pathologies, like people with AIDS, people with severe tuberculosis, and we just didn't have the capacity to do everything. So yes, even in Europe, at some point, hospitals were overwhelmed, but in countries with lesser health capacities, it's even more. important. So, but then even knowing that, there's still a significant number of people who do not want to be vaccinated or who doubt that vaccines are useful. So what can we do different to convince people to get vaccinated?
Yeah, that's a good question. And I think one of the things that frustrated me during this pandemic, and I'm sure many people who work in some kind of element of health promotion in MSF or otherwise in the humanitarian world, know that the community reach out is the most pivotal strategy that you have, right? You can have all the tools, you can have vaccines, you can have drugs, but if you don't do community reach out, the community reach out is not just putting posters, it's not putting commercials, it's actually having a dialogue with communities and why things are important. You will lose. You always lose the battle against whatever pathogen it is. Now, it seems like in Europe, for us, this was a mystery. We had no idea how to interact with communities. We thought we organized press conferences, we do posters on walls, and voila, we're done. People will understand it. But in no way is the population in Europe different. And especially with the era of social media, and I'm not just talking about the Facebooks and Twitters, I'm also talking about the family WhatsApp groups and things like that. You're basically running a constant campaign against misinformation that's packaged in the most attractive way, a 20-second clip that has been cut and pasted in the most applicable form that makes it easy. While if I'm trying to explain something like in this seminar, I use a lot of minutes to explain it, and that's sometimes way past our attention span. The best strategy that we always had was dialogue. And in Europe, we've massively failed that. But in other countries that have a lot of experience on day-to-day basis with outbreaks, for example, after the West African Ebola outbreak, everybody knew how important things like risk communication and community engagement was, how important the inclusion, not just of medical, biomedical staff, but also of social scientists that learn to understand communities, that know how you should communicate with communities, how you should start a dialogue, were really important. Now, I always said, like, maybe in Europe and all parts of the world, it's relatively easy to get to 50% vaccination coverage, to say so. If people see the priority, if they've seen how our hospitals got overloaded. But then the curve starts to smoothen down. It's not going so smooth. And the last phase to convince people to get vaccinated is really door-to-door work. It's really, general practitioners having a dialogue with their patients. It's really people in, let's say, the regional health institutes trying to organize things on community level, finding spiritual leaders, finding, let's say, the social media images like the top football players, the Instagram stars to help them convince it. And in Europe, I'm sorry to say, in many countries, we have failed to grasp this understanding. It's hard work, community engagement. It's tiring work, and you explain the same thing over and over, but it's also the only way.
It's the famous Pareto principle. It takes 80% of the resources to reach the last 20% of the people are doing.
Exactly.
Yeah. Okay, so now something different. Israel and Spain and other countries carry the voice of return to normal life, live with COVID, and then other countries like France or Luxembourg talk about compulsory vaccination. Are they going the wrong way? Why are governments making vaccination mandatory? What do you think about this?
Yeah, I mean, this is very much a personal opinion. So, like, as a human being, I'm not in favor of forcing people to get vaccinated. I think, especially in a tense political climate in many countries, that can have adverse effects as well. I'm not talking about medical adverse effects. I'm talking about, political adverse effects. You see massive demonstrations and things rising. And that sometimes I think if very early on we would have set into community engagement and explaining things to people and really actively combating misinformation, that would have yielded a better result. At the same time, like you said, Sheil, we hear a lot of countries talking about the return to normal. I think in the last 2 weeks, it has dominated all news headlines. The COVID is past, Omicron is the last phase, and it's done. But by no means, can we say that? Because we have not reached the phase of stability yet. infections are soaring in Europe. We've never had this many infections in the history of this pandemic. And there's still a risk that in many countries, health systems will still get it a little bit difficult. And I think that is also kind of the warning that people once again say the pandemic is over, which happened many times, right? It happened after the first wave, we said the pandemic was over. It happened after Delta got introduced, we said it's over. When the vaccines were introduced, we said it's over, but we don't know that yet. And we all want to so desperately return to normality as well. But I think we also kind of have to think more about, what is the new normality? Which means that maybe at some times of the year, it's normal to wear the face masks. Maybe during some times of the year, it's normal that you say, hey, listen, we're getting so much infections, we need to have at least some basic measures in place. The new normal doesn't necessarily mean the old normal, to say so. And we have to be cautious about that. And that's what makes this crisis so darn complicated.
Yeah, it is complicated. Now, the last question about vaccines, we speak about possible end, but as you said, we really don't know. Also, many people feel like COVID is the worst epidemic we've had, but of course that's not true. We've had the plague, which killed a third of Europe's population in a couple of years. We've had the Spanish flu 100 years ago. How do you rank the possibility that we will face a much more deadly mutation of the virus, a much more dangerous virus that could spread like Omicron?
I think if you look at the rise of pathogens, there's a few factors in play. One has to do obviously with zoonosis, which is the chance of viruses jumping from one animal to another animal, like us. And that has two factors. One of them is definitely the increase of massive amounts of people living together in close proximity to, for example, animals. And actually, nobody really thought that it would be a coronavirus that would be the next pandemic. Everybody was always hypothesizing the new disease X, the new one that we need to be afraid of, is probably going to be a new flu variant, because flu mutates in higher frequencies. It has the potential to very easily jump and change all kinds of segments from one to another. And that challenge remains, and that risk remains. And I think this risk always remains, and it has given us the responsibility to make sure that we get ready. Getting ready simply means, in many ways, investing in basic healthcare. It sounds so simple, and in many ways it is, because you can prepare to a certain degree from the unknown. That means, for example, having countries that more and more can detect what is circulating in terms of disease, but also countries that can respond to it. And you see that countries that had many outbreaks, for example, countries that had several Ebola outbreaks, are now much more resilient and much more quickly capable to handling new outbreaks. Let me take Guinea. Guinea was one of the countries where we had one of the last Ebola outbreaks. But in 2014, 2016, it was one of the countries where we had the largest Ebola outbreaks. They invested so massively in things like contact tracing, which we're also using during the COVID pandemic. They have invested so much in community-based surveillance. So the last Ebola outbreak was halted at a very early stage. They only had 8 cases because they jumped on it so early. That's the investment that we need to be looking on. Because the resilience of health systems, regardless of the disease that we will have, will really guarantee, the best possible outcome for whatever may come.
And you're right to talk about flu, because with COVID measures, flu has decreased all over, at least rich countries, but that also means immunities are going down. So I wonder what will happen when COVID is finally over or much decreased, and most of the measures, protective measures away, will most likely will get a surge of influenza, of flu, and I hope it will not be a bad one.
Yeah, I mean, there's two sides to that, right? The measures were incredible. The measures against COVID were incredibly effective against the influenza, the flu virus. Now, that means there was less flu, so also less chances of mutation, but it also means less people were exposed, so there's less immunity. Now, we do know that immunity against influenza is typically very strong, so once you got it, but because the virus mutates sometimes so fast and it jumps from one animal reservoir to another, that we run into the risk. Normally, this would be the season in Europe for the peak of influenza. We're not seeing it yet. We saw that the variants that were circulating in the south of Europe were quite worrisome. And we'll see now that we are building off measures in many countries. What does it mean for influenza? We saw that in children with the RSV virus, that all of a sudden you got small outbreaks that really stressed the pediatric intensive care units in many countries, because RSV was not seen for, well, at least a year, to say so.
Yeah. Okay, now let's move to what I think is the most important part of the webinar. The most important topic, it's vaccine equity. We see everyone is very much focused on what's happening in country and looking at infection rates, vaccination rates inside Luxembourg, inside France, maybe inside Europe. But as we see over and over again, COVID is a global problem. And as long as we don't see it as a global problem, we'll continue to get bitten by the effects of the neglect of vaccination in poorer countries. New variants will continue to emerge as long as vaccination rates are low. So coming to that, there's a question saying, can the vaccine put an end to the pandemic? Will the virus stop mutating if we manage to vaccinate the entire world population? Or, let's stop it there.
Yeah. I mean, yes, if we vaccinate everybody in the world, however you can imagine to achieve that, yes, the chances of new variants arising will decrease because you have simply less virus circulating because there are less people getting the virus. And when that's the case, it also means that you, with less circulating virus, have a lower chance of new mutations happening. So yeah, that is absolutely like a go-to strategy. The question, of course, is this practically viable? And that's a very complex question, and that everybody is hitting their head on. One is the equity of access. Of course, when it comes to equity of access, we've seen basically a moral failure in that sense. And when even before the vaccines came to the market and COVAX was established, the rich countries were hoarding vaccines. They were making bilateral deals with each pharmaceutical. They stocked so much up they couldn't use it, and the leftovers were donated sometimes, but also in a lot of cases just simply destroyed because they reached the end of their shelf life. And I think that's the bigger picture that we want to address. We were hoping for charity. We were hoping that the rich countries were going to donate to countries that couldn't afford it or simply didn't have access to the vaccines. That didn't happen. And I think that lives also for us as MSF, as an organization, once again, as the MSF Access Campaign does brilliantly for years, putting the underlinement that aside from the COVID question and COVID vaccine questions, it's like, how do we support and stimulate the sharing of knowledge? Much of the knowledge developed for the new generation of vaccines that we have now came from public resources. They were developed at our universities, they were developed at our research institutes. How do we share that knowledge better? And the other question is, of course, what are the mechanisms that we can use or that we can stimulate to increase production capacity in regions itself, so that regions are not geopolitically dependent on a charity? Because the vaccine equity was one part of the story. But when we had shortage for tests, there were also no reagents available for big parts of the world anymore to do testing. We saw that also with the personal protective gear. And we were struggling here in Europe to get them. For the rest of the world, there was nothing available anymore. So that independency is also a necessity. So either we help and contribute to that necessity, or countries will claim it for themselves. They will say, listen, we saw in this pandemic that friendship doesn't exist. We saw that charity doesn't exist. So out of our own protection, we need to move in that direction. And I'm always happy to see that MSF is also a big proponent to this and pushing this agenda as well.
Yeah, yeah. And we are very far from getting to anywhere close to vaccine equity. There's still a number of countries with less than 10% vaccine coverage, many more with less than 40% coverage. And so initially, the World Health Organization proposed the COVAX system, or the COVAX initiative, which was an initiative of more than 160 countries, I think, that was going to coordinate vaccine distribution to low and middle income countries in an equitable way. How has that worked?
Well, when these discussions around COVAX started, well before the vaccine was there, I was working at the International Committee of the Red Cross, advising specifically on this dossier. And based on the lessons we had learned already, namely that Western countries were hoarding their protective equipment, we immediately knew, listen, it's a great idea on paper, but it's not going to work in practice. So the thing is, like, it's great to have these idealistic ideas, but the question is, like, how are we going to enforce them? And even now, when it comes to something which is called the TRIPS waiver, which basically says, hey, we're not talking about the latest patent for the newest model iPhone. We're talking about life-saving medicines and vaccines. We still fail. To share the knowledge, to simply say, listen, this knowledge was generated in a public arena, let's share it. There are fortunately new initiatives starting. There has been this new vaccine, which is called Corbevax, which has been developed by Texas University, by some proponents who immediately said, we developed this vaccine and we basically share the knowledge. And now the vaccine is produced in India, and it's gonna, being produced in massive numbers to kind of show that yes, there are more equitable ways of achieving equity when it comes to the distribution of life-saving medicines, vaccines, etc.
Yeah, thank you. I mean, that opens up to one very big question, but an important one is, how would you propose to advocate better on an individual level for people listening to us to promote vaccine equity? What can we do?
Yeah, I think what we should do is put a proper voice in order. On one side, you have the pharmaceutical companies who clearly have a financial motive, and they had massive profits over these vaccines. That doesn't mean that vaccines are bad or anything. I mean, they're still good and we need them and they're super important, but it does mean that they have a different angle, which is not necessarily saving lives in the largest number of people, but it's making a profit. They have their stockholders. We have to showcase the good examples and echo the good examples of how things can happen as well. In the 70s, India said, for example, for the hepatitis B vaccine, they very nicely knocked on the door of pharmaceutical companies and said, hey, we have a lot of hepatitis B. We need those vaccines. Can you help us sharing the knowledge? And they said, no. India said, well, if you say no, we're just going to develop them ourselves. Nowadays, India produces 70% of world's vaccines at most affordable prices. Which makes the vaccines accessible. Now, that's a model we need to showcase. This Corbevax example for the COVID vaccines that I just mentioned is another example of how it can work in a better way. Everybody who goes into science, I have to say, the vast majority working in science, go there to make the world a better place. And I think it's our joint responsibility to keep that in mind, that, when pharmaceutical companies come with all kinds of arguments like, no, in Africa, they don't have the knowledge to produce vaccines, we can tell them, listen, South Africa, there were some small startups that produced vaccines for a while. And why can't they do it? They have enough knowledge, they have enough people to do it. And our role as MSF should be to echo that, to support it also in our projects, to kind of lead that movement by example. And we have done that for many years with the Access campaign. So echoing it, putting a counter voice against the pharmaceutical industry that, yes, there are better models is really the way to go. And there is no better moment to do that than at the peak of the current crisis, which has very clearly displayed that inequity.
Yeah, so you answered partly the next question. I mean, people were asking, how can we reach, it's a very big question, reach more justice in global health? What is the right to health? Why would it be more effective than a waiver of patents to fight pandemics faster? I don't know. I mean, do you want to answer that, or you feel your previous answer was enough?
Listen, I think either we move with the flow and we say we're going to facilitate it, or countries are going to claim. John Nicholson, the director of the former director, I have to say, of African CDC, made a very clear statement. Charity doesn't exist. So as an African continent, we have to take it in our own hands to say, okay, we need that development. Imagine what it does to the trust for people to say that in the world's biggest global crisis, the West said, or the North said, no, we're not going to help you in the way that we optimally can do. We're going to decide what we need first, and then you come not second, not third, no, you come on the 10th place. That by itself drives the necessity for change. And as MSF, we are on the front of that, to echoing it, to bring it to the political stage as well, both on the level of, let's say, the international politics to keep on pushing, but also on our local levels, on our association levels, to speak with our ministers of development aid, to counter the arguments of sometimes a very strong lobby of the pharmaceutical industry. We need to get more organized. We need to get more focal in its stance on a national level as well, and put the pressure. MSF Netherlands, for example, they did this really nice piece of research with a polling agency. They checked how many people thought the Dutch government was doing enough to address vaccine equity. 70% of the people thought they didn't do enough. But by doing that poll, by creating some media attention with a simple activity as a poll, they put additional burden for the Minister of Health to react, and for the Minister of Health to say, okay, this is what we are doing. If we don't do these things, also our countries can get away with it about doing nothing. And I think that is really the role that we as MSF can play on the international level, but also on a national level.
Yeah, no, absolutely. I mean, you have it in your office somewhere. The president of MSF, when he received the Nobel Peace Prize, he said this very famous sentence: "We don't want charity, we want change." And this is definitely what we should try to do, but it's a hard one. Listen, we have to draw to an end slowly. There are many more questions from previous people, also in the Q&A. So I'll spend maybe the last 10 minutes with one last question on equity, and then go to the questions that are in the chat. Well, so my last question, and I really feel with the person who asked this. He says, I live in France. I firmly support vaccine equity. I work for MSF, an organization that supports vaccination. I've taken the vaccine and the booster, and I encourage my family to, because without it, we're denied access to public life. But he says, it creates an ethical tension for me. At 50 years old, 2 vaccines are probably enough for me. And we know that currently there are 15 times more boosters given than first dose vaccines. So I would have happily not gotten my booster and given it to people in developing countries. So, how would you propose we act on that? And is refusal an option? What's your take on this?
Refusal is always an option, but the question is, what will you achieve with it, right? And I think we need to be careful sometimes to say, okay, I'm not going to take the booster and then expect that this booster will end up somewhere else. It won't, unfortunately. That has to do with the incredible complexity that we have created. And when I say we, our governments, together with all the legislative barriers in saying, for countries, it's not so easy to directly donate the vaccines they have on the shelf to other countries. It has to do with liability. So that's what we've seen. Governments sometimes prefer to destroy vaccines than take the responsibility of shipping the vaccines. So you not taking a vaccine as an individual, unfortunately, is not going to make a case. But to be honest, it should also not be necessary. It's not that we have a global shortage of vaccines. We just have an inequity in distribution not because we getting our boosters, but because our governments are not playing the role when it comes to sharing. We also have to be honest. When vaccines, two of the highest risk factors of getting severely ill from COVID, from a SARS virus infection, your age plays an incredible risk factor, and underlying disease, cardiovascular disease, diabetes. Fact is also that, let's take the African continent and all its diversity of examples, that the average age there is about below 20, compared to Europe, where the average age is around 43. That's a huge difference in risk factor. That doesn't mean that nobody on the African continent runs any risk, but you need to, put your campaigns a little bit more targeted. In our case, it might make a lot of sense to vaccinate because we have many people at risk. In the African continent, you have to maybe do more targeted vaccination campaigns. You have to invest more in the logistics as well, of getting vaccines here and there as well, because the vaccines that we have, they're all cold chain vaccines. But again, for me, this shouldn't be a choice. It should be and not or, especially on the individual level. So I think that's an important part to also bring forward in the advocacy. And what I also speak to some of the MSF colleagues that work on these discussions on how can you, influence the public. Yeah, you shouldn't tell the public not to get vaccinated, but you should tell them to push their governments to, share the surplus of vaccines, to find what the real barriers are in sharing knowledge, in building local production capacity, and have some honest conversations about it, and not all that, to say it in a bit less friendly word, better about bullshit about sharing of knowledge. We can't do it, blah, 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 because we have shown in history that we can, and that there are better models available.
Yeah, no, thank you for this. Indeed, reminding us of one of MSF's mottos is that silence kills. And we do have a voice, and we should use it. And that's probably just refusing the booster is probably not going to make that much difference. But using your voice to put pressure will.
It's one of the reasons I joined MSF, right? Not just because of the medical care, but it's by opening your mouth based on data, based on evidence, but to push the advocacy agenda.
Yeah. So there is a question from Trésor Kangishi who says, why does MSF not work in vaccines in the world? So
that's a question I think, Gilles, you can answer much better than I do, because I can just say the world of vaccines is tremendously complex, and it's much better sourced to, let's say, academic institutes with massive laboratory capacity. And yes, also the pharmaceutical industry has to play a role in scalability, to produce it, to have proper quality assurance. It's an art by itself, to say so. As MSF, we're an emergency organization. We react to the emergency. We use the tools like vaccines for malaria bed nets, or for TB, other, different complex drugs, that every organization has their role to play.
Yeah, absolutely. We just, MSF is just not made for that. It's would not have the resources to do it. It's a really different thing to make vaccines and to provide humanitarian aid. Roger Martinez is asking if you could give a historical comparison with another pandemic. How variant dangerousness evolved and how it became normal or endemic. And it links to another question. That's why I'm asking it, because people are also asking, what would be the endemic stage of COVID-19?
Yeah, I think we're being challenged on what we mean with endemic. Just like we were challenged previously in this pandemic, what herd immunity actually means. And I think when we talk about an endemic situation, we talk about a form of stability, predictability, and we're simply not there. If you look at, let's say, let's call it what they previously called the Mexican flu in 2009. That is a virus that was also lifted as what we call a public health emergency of international concern, but for some reason, it never got to that degree of severity. If we look at the Zika pandemic in 2016, I was very active in that part of South America and the Caribbean, where many cases were found. That is also a pathogen that was differently transmitted through a mosquito, which is very embedded into climate change. So all these diseases have their intrinsic dynamics. And when you reach an endemic stage, you talk about some form of stability. Even because the disease was actually not as bad as she thought it to be, or because many people got exposed but got not severely sick, and now you have long-lasting immunity. And we're not simply there with this pathogen. I always compare, SARS-CoV-2 as a complex virus in the sense that most of the time it's like an underground fire. You see some smoke and people are like, hey, what are you talking about? There's nothing happening. And then all of a sudden you have no measures in place. And then all of a sudden it becomes a big fire and then it turns down. And that's the wave pattern that we have seen. So to that extent, it's a bit of a unique animal in itself for a respiratory virus that is. So that makes it also such a complex emergency because it's long lasting and there's still so many uncertainties left. Societies get tired. We get tired as professionals as well, talking about this virus, especially in MSF. There's so many other things that we should focus on, neglected diseases that have a huge impact in the countries where we work, TB, HIV, malaria, measles, routine vaccination programs that are interrupted. So yes, to that sense, it's also making sure, yes, that there is a real pandemic ongoing, but all the other things have not stopped. So for us, MSF, it's also important to focus properly.
Yeah. Thank you, Amrish. I think this is a perfect ending to this webinar. I want to thank everybody for attending. Thank you, Amrish, for sharing your views. So yeah, vaccines work. They're very unequally distributed at the moment, and you can use your voice to make a difference, to put pressure on governments to change this situation structurally. Before we close and leave, I'd like to invite you to the next event MSF Luxembourg organizes on Wednesday, the 26th of January from 12:30 to 1:30 about MSF's work with Dr. Mark Baidjoe, the Director of Operations at MSF Brussels Operational Center. And you can find the link in the chat. After the webinar, you will receive a satisfaction survey. Please let us know what you think in order for us to improve the next events. But mostly, thank you very much for attending and showing that you care. And information is one of the most, and it's very hard to get the right information. So we hope this webinar has helped a little bit towards that. Thank you.
Good evening, everybody. Keep safe.